My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Brigham and Women's Cancer Center. Our management of the axilla has really evolved over the last 2 decades. We used to think that anyone with positive lymph nodes required a lymph node dissection, and then we started to see results from the ACOSOG Z11 study, the AMAROS study, and other smaller studies out of Europe demonstrating for us that in women with low volume disease in their sentinel nodes, that axillary lymph node dissection did not contribute to improved rates of regional recurrence and did not improve survival. And so we have had this real awakening that not all disease or not all microscopic disease in the axillary lymph nodes requires further axillary surgery. In ACOSOG Z11, they included patients with both micrometastatic disease in the sentinel nodes as well as macrometastatic disease in the sentinel nodes. And amongst those women with 1 to 2 positive sentinel nodes who were all treated with breast conservation therapy and whole breast radiotherapy, there was no difference in local regional recurrence at 10 years based on the performance of a lymph node dissection, and no difference in disease-free survival or overall survival based on the performance of a lymph node dissection. Now, the important things that we all noted about Z11 when it was first published was that it only included women with breast conservation therapy. And therefore, the question became, well, can we extend these findings to mastectomy populations? And this led to a lot of focus then on the volume of nodal disease. Are we micromets versus macromets? And we know that Z11 included both patients with micromets and macromets, but there were subsequent studies, including the International Breast Cancer Study Group 2301, I believe is the number, that only treated patients with micromets in the sentinel nodes, but included women having both breast conservation therapy and mastectomy. The difference between Z11 and International Breast Cancer Study Group 2301, we can highlight the difference again between the volume of disease in the axilla in women with micromets versus macromets, in that the arms in the trials where the women underwent lymph node dissection, we saw that in the trials limited to sentinel lymph node micromets, the likelihood of having additional disease in the axilla at the time of node dissection was 13%, compared to Z11, which included both micromets and macromets, the likelihood of having additional disease in the axilla in the arm that underwent node dissection was 27%. So we do see a distinction between the likelihood of additional disease in the axilla does vary based on the presence of a micromet versus the presence of a macromet. But both of these randomized trials demonstrated for us that in women with disease in a low volume of disease in their sentinel nodes, defined as 1 or 2 positive nodes, that whether it's a micromet or whether it was a macromet, that we could safely omit lymph node dissection in this setting. Now, I mentioned the International Breast Cancer Study Group included both breast conservation therapy patients as well as mastectomy patients, but some would argue that there were very few mastectomy patients represented. Only 9% of the women in that study had mastectomy. But when we look at the AMAROS study, AMAROS also included breast conservation and mastectomy patients, and AMAROS also again included micromets and macromets, and randomized patients to either lymph node dissection or axillary radiotherapy in lieu of lymph node dissection. And in this study, we also saw no difference in local regional recurrence rates, disease-free survival, or overall survival based on the performance of a lymph node dissection. Again, all of these studies were in women undergoing upfront surgery, and all of these studies contributed to this increased, again, awareness and acknowledgement that not all microscopic disease in the lymph nodes requires surgical management, and not all microscopic disease in the lymph nodes will result in axillary failures. And in fact, across all of these studies, isolated axillary failures are extremely uncommon in the 1% range, and patients who do have subsequent events are much more likely to have either local recurrences in the breast or distant disease. So surgical management of the axilla in women, particularly with micromets, can be limited to central lymph node biopsy. There does not appear to be any type of benefit with respect to local control or survival by performing additional lymph node surgery. Now, one topic that may come up in some tumor board discussions is the rest of the multidisciplinary team may say, well, I'd like to know if there's more disease in that axilla. Is it only micromets, or is there potentially additional disease in that axillary basin? And again, here we need to refer back to those randomized clinical trials where women were randomized to either observation or node dissection. And we know among women with micromets in their nodes that consistently about 13% of the women in the lymph node dissection arms were found to have additional disease. So really only a minority of women will have additional disease there. And so as a multidisciplinary team, we really do need to strive to be able to make our treatment decisions based on the information from the sentinel lymph node biopsy procedure, and not put women, in need of lymph node dissection and that morbidity from lymph node dissection, when really the clinical evidence is strong and is sound that we do not need lymph node dissection with micrometastatic disease, and that these women have excellent outcomes, and we should be able to make our multidisciplinary treatment decisions based on that information alone.